speakers. The session is now open to questions, so do please feel free to come to the microphones. There are some questions that have already been sent in remotely, which I'll go through. But I see Derek at the first microphone. Derek.
Thanks. Excellent session. Fantastic. And it's nice to be back. It seems like I didn't leave from 2018. It looks the same. Hassan, I want to ask two questions. MDTs, which I'm obviously we're all very supportive of, and it's made a big difference. But in this disease, it's slightly counterintuitive, the MDTs, because sometimes the MDTs are very heterogeneous. They have people who are not as experienced all the time, and the decisions that get made can be variable depending on which week it is, how many patients are on MDT, how quick you have to get through it, and who's in the room. So how can we, because I do think some of the radiology undercalls the disease. I think without experienced surgeons in the room, different decisions are made. How can we deal with that so that we get equity across all MDTs?
It's difficult in that. I mean, MDT is not just the meeting, you know, so all I can talk about is what we do in Liverpool, and I'm sure in Leeds and Newcastle is similar. We have a core group who really work on this, and it's important that the MDT is core-rate and sending at least, you know, one if not both of the surgeons doing cholangiocarcinoma-based work will be at that meeting. The difficulty is the time that you have to discuss a case. And often the MTT is more of a screening tool. You exclude metastatic disease and things, but the nuances are often an ongoing discussion on a case-by-case basis and between that kind of core team. But I completely agree that, you know, what would be interesting, and I don't know if this has been done, is to have standard cases that are put through in a blinded fashion through an MDT across the country and see the variability in decision making. I know within, say for example, sarcoma surgery, that has been done by the Birmingham group, and we, as well as I'm sure Newcastle, has added to that work. So it is a challenge, but I think it starts with, personally speaking, having a core group that manage this disease, not just one surgeon doing an operation once a year.
Specialized, maybe a specialized MDT.
Yeah, so you can have a HPB MDT, but it's super specialization within
and Juan, can I just ask, Raj and Maria, so my role...
So just before you quickly do that, could I just continue that question? It's actually coming from Sarah Tilley online. Again, to Hassan, you talked about MDTs being crucial to patient care. How often should a patient be on an MDT? Is it after every scan or every 3 months? So what's the regularity of that?
Again, there's a capacity issue, you know. So to me, every newly diagnosed patient, assuming they want to have active treatment, should ideally be discussed at whatever your regional HPB MDT is, and that varies across the UK. But that discussion shouldn't just stop at your district general hospital level or your GP level or whatever. So that idea of having that case put in front of that tertiary MDT, I think is a must. At that stage, the patient's care will be, you know, triaged based on whatever pathway they're going to follow. Now, if you look at the surgical patients, they may have one or two discussions as additional information comes through. So increasingly, we're doing PET scanning, and that information comes back subsequently to the MDT for discussion in terms of proceeding towards a surgical pathway, let's say. But then once the patient's been followed up, we would only rediscuss that patient if on subsequent imaging there's suggestion of metastatic disease. There's no need to discuss a normal scan, for example.
So problem solving. Yeah. Thank you. Sorry, Derek, go ahead.
So just to Raj and Maria, so in my role as the medical director for transplantation, this is really important to make sure this happens. And I've been very supportive of it. My concern is proton beam therapy is going to be the stumbling block we face. So in the interim, is there any way we can move this forward with using SBRT or using some other form of radiotherapy, because I can see this being delayed for another year, having had discussions with NHS England about 3 weeks ago.
Maria, would you like to start off and I can follow?
Yeah, I can respond. So, from the institutions are ready to deliver the treatment. The stumbling block is within NHS England.
No, I know that.
And secondly, there is no expertise in the UK to give the Mayo Clinic protocol. We do not have brachytherapy.
But do we need brachytherapy? Because actually,
To my knowledge, yes.
but there are other places in the world that don't use brachytherapy.
Okay, so this is a very difficult and delicate situation. We've agreed to go on a path. We agreed to have a protocol, and I think we're all trying to work together to open the access to patient as soon as possible. From my perspective, at my institution, we can do this treatment all the time, but the green light is not with me.
So, thank you, Maria. So I think you are right in saying that some of the, as I mentioned, Netherlands, they don't use any neoadjuvant therapy. And when you discuss with some of the Mayo Clinic people and people who wrote the papers, they say brachy is the most variable bit we use. So I suspect we, as you know, we've set ourselves a deadline, and if we are getting closer, we probably need a Plan B meeting reorganized again. So I think we
Well, we'll leave it there. Plan B.
yeah. Thank you.
Thank you very much, Shahid.
Hi, thanks. A great session, everyone. My question is about transplant as well, primarily to Raj, but really the whole panel. So it's about the impact of deciding that we have to have histology. So if you look at the original Mayo data, where they got this neoadjuvant treatment before the transplant with chemotherapy and radiotherapy, at explant, when the liver with the cholangiocarcinoma was removed, a significant number of explants had no cholangiocarcinoma. So the oncologists involved would say, well, they had an excellent response to the neoadjuvant treatment. A cynic would say they probably never had cholangiocarcinoma in the first place because you never actually proved it with histology. In other centres, have they that have comparable data, have they also insisted on the histology, or did they go down the Mayo route and say you don't have to have histology? And if so, if we're insisting on histology, do you think we're going to achieve similar outcomes?
Thank you, Shahid. The easy answer for me is to deflect it to John, Juan, and Maria here, but I will start off here. It's the glass half full and half empty story. So what is interesting is that if you look at the neoadjuvant therapy and transplant outcomes in non-Mayo centers, it's inferior to what Mayo has found. And no one is able to replicate the same outcomes as Mayo replicated. So you have to ask that question. Some of them may not have had the cancer, what they assumed. So if you start off with that, then we are embarking on a service evaluation using precious resources, which are there's a huge queue for these organs. And these are the discussions we had in the evaluation group with oncology colleagues. And I think everyone felt we have to be sure that there is cancer while accepting that we may miss some because of lack of positive histology. And part of the data management will include group of patients where we couldn't get a positive diagnosis and following them up and see what happens. Accepting that a percentage of patients will be doing disservice, but also we're learning from that and then able to modify what we are going to do. So I think that's how we set out. But is there anything, Maria?
So try and do is also obtain liquid biopsies, because perhaps if a positive liquid biopsy and a negative tissue biopsy are found, that we might reach some compromise. So that's why we will have multidisciplinary team meetings to discuss these cases. The challenge is that I'm not sure whether all the centers can do the liquid biopsy, but that's something we can explore.
John, can I ask you to comment?
Yeah. So if you look at the long-term survival of patients who never got a transplant, never got an operation, treated with radiation and systemic treatment, it's not as good as that. Okay. So did some of those patients never have cancer? Almost certainly. The reverse, and I put the reverse argument to him, which was, when we come to publish this, the first and major criticism of anything that we do will be that we'd never got, that some of these patients would not have definitely confirmed cancer. And will it make the results worse? I don't know. It's not possible to answer that bit.
Yeah, no, I personally think it's the right thing to do to insist that we have histology. My only concern is that my concerns are that we weren't allowed to transplant for cholangio for decades. We've got a window of opportunity. If we don't show good survival, that window closes again for a period of time at least. So on the one hand, I'm conflicted because I think we got to have positive histology. But on the other hand, if that's going to affect the overall survival rate, is that then going to lead to a discussion saying, well, should we transplant?
So the rest of the rules have to be very good and have to be stuck to. And they have to be small tumors. They have the patient has to be properly screened, and I think we just have to be very, very ruthless about sticking to the rest of the rules.
Yeah. And I think Helen and Martin had very clear views and was very, we were very keen to get that input on a small percentage of patients may have disservice, but if we transplant someone without a cancer and have all this treatment, that would have been a bigger problem. And I think we had huge support with this protocol. So.
Thank you. We've got 99 people online looking in, and Olivia Phillips has asked, I would love to hear more about the significance of lymph node involvement in patients with cholangiocarcinoma and treatment options, particularly with relation to surgery or SERT. Maybe Hassan, you can take that one.
Yeah. So this is the difficulty. So we looked at our patients with resection who perhaps would have been transplanted if they were in the US. And this was the small tumors, node negative. And with resection, their 5-year survival was around 80%. So when you look at the series where you have the de novo cases, for example, in the US, and transplantation is perceived to be good, in those cases, I'll get to the point in a second.
He knows me well.
Yeah. When you look at those US series, what you find is that their overall survival for cholangiocarcinoma across the board is actually far less than what you have in the UK or in Europe, and they're doing an average of 3 cases a year. But when we looked at this data, if you had node-positive disease, the 5-year survival is probably around 30-odd%. So node positivity in itself is a very bad prognostic factor. Now, if you talk to the Dutch group, the AMC group, if they find a station 8 lymph node which is on the common hepatic artery, and this is getting very technical, they would stop at that stage because they would believe that that is perhaps futile surgery. It's not something we would do, but that's perhaps something that would be done there. I think periaortic nodal disease, to me, would be an absolute kind of contraindication. This is where we really need to get to the multimodal treatment options. Obviously, we have the adjuvant therapies that are established. The neoadjuvant therapies are the areas perhaps where we need to get to in the future. Remember this, certainly for the perihilar tumours, these are operations which have significant morbidity. These are patients who are stented, trying to get a patient through months of chemotherapy without developing cholangitis, and, reduction in the performance status isn't straightforward. So it's not an easy answer, but it does impact outcome.
Thank you very much. Rahul?
Once again, thanks to the panel for the discussion we had. My question is mostly surgical, and moving on from where the issue of MDTAs and resectability is, we know it's incredibly difficult. Let's take it a step further, and it might sound a very philosophical but incredibly practical question. You decide to operate on someone who's borderline resectable. And how do you how do you mind your decisions intraoperatively when you know, for example, that the operation is going to be incredibly tricky, you risk an R1 resection, and at what stage do you bail out, realizing that you may be trading what sounds like a 15% perioperative mortality, or even more for these complex cases, for no more than, say, a 20-25% 5-year survival? What is your outlook, and perhaps all the surgeons in the room, about how far do you push things intraoperatively for the sake of what might sound to you as a surgeon as a resection? I've taken it all out only to find out that really, in reality, the outcome perioperatively and instantly postoperatively has been rather poor. In those cases, it is better to abandon surgery, knowing that a localized tumor may give a fairly long-term survival if it's well controlled oncologically and drainage-wise, rather than risk a quick perioperative mortality.
Thank you, Rahul. There is no easy answer to that. It applies to every cancer surgery we do philosophically. So I say cholangiocarcinoma surgery is probably, has the longest learning curve I had, and I continue to evolve. I operate on probably lesser number of patients I select, but the ones you select, you tend to be more aggressive because you know that hilar cholangiocarcinoma, local regional clearance is far more important than anything else we do. So it depends on if you've taken someone for surgery and if you believe that their risk benefit, you would know the risks you are putting them through before you operate. So if once you decide to operate, unless you find something you can't remove, that debate doesn't.
The issue, Raj, is that you know the risk what you're undertaking preoperatively. Intraoperatively, you find that the risk is much, much higher.
You prepare you counsel for the worst risk before you proceed. Anyway, that's how I see that. It is what you find out on whether it's no longer about the risk, it's about the cure. If you think the survival is going to be poor because there's a lymph nodal spread or the tumor, or you're not going to get a negative margin, then you back off. At that stage, in my mind, it's not about the risk of mortality, it's about chance of cure. So that becomes, that's how I look at it. But I'm sure we all have different views.
You're right, it's a very philosophical question. I think that can carry on over lunch. Thank you very much. Vincenzo.
Yeah, very quick question. Because we see that to candidate patients to transplantation, but also to resection, you need to have very early diagnosis. I want to ask to Professor Prasad if you are implementing screening and early diagnosis in PSC patient, for example, or chronic liver disease.
Thank you. I'm still a simple mister. I'm a bit of a misfit here, but I think it's a very interesting question, and I think screening of patients with PSC is something my hepatology colleagues here, my physician colleagues are very passionate about, and I think I won't be the right person to answer that. But I wonder if Shahid or Simon, if you could have any views on that, if I may.
Yeah, our protocol is, I think, the one that everyone used to perform 6-month imaging, ultrasound or MRI. But this not seems very helpful for early diagnosis. So I don't know, since you are leading the transplantation, And another comment, in my opinion, for the intrahepatic, probably we need to start screening advanced fibrosis in non-NAFLD patients, in my opinion. This will lead us probably to increase the curative approach.
Thank you. And as a surgeon, I agree with you about picking up the early tumors, but unfortunately, most of my physician colleagues may not support repeated scanning. You know, am I?
So I'm going to have to draw this to a close because time has actually beaten us. You can see that when you've got us talking about our favorite topic, we can go on and on and on. I'd like to thank all members of the panel. And if you do want to pick up any further questions or further discussions, do please touch base with any of them during the breaks.